So I'm here with my partner, Margaret Keavney. We have a law firm called Keavney Streger that focuses on EMS and healthcare law. Both Margaret and I are EMS providers in our past lives, if you will, and we have clients that are EMS providers and agencies. We're also happy to be joined here this evening with Rebecca Rakowski and Jordan Fisher from the law firm, the XPAN Law Group, who specialize in cybersecurity and other internet and computer law. So say hello, Rebecca and Jordan.
Good evening, everybody. Evening.
So I want to thank Rick Mosteller, whose voice you heard a few minutes ago. The folks from emsCharts and Penn Care have very graciously offered to sponsor this webinar that we're doing today on EMS data collection efforts. And they've done this, although we will talk about the emsCharts product here. The goal here really is to be agnostic and talk about the law and talk about the requirements of this new law that passed and how they apply to EMS agencies of all kind, and really to talk about the things that you might not anticipate, how they apply to your agency. So I'm going to flip slides here, and hopefully there's not too much of a lag time, and it seems like we're moving pretty good here. So just so you guys know that this law, when it passed, I had some conversations with some folks from the Office of EMS in the state, and while they aren't participating in our webinar today for obvious reasons, they did have a couple of messages that they had asked that we send on their behalf. Specifically, it's important that you guys know that this law does not have exceptions. It's very clear. It's a very straightforward law. It's actually a very short law to read. And if you look at it, you'll see that it has a very targeted applicability as to who it applies to. It's important to note you don't have you as the agency have a specific responsibility to comply with this. There's no exceptions. There's no real way to get around this one. This is pretty locked in here. So at the end of the day, while this might be difficult for some of you and it might be onerous at times, and you might wonder why me, at the end of the day, the fact is that this really does apply to everybody. That being said, the Office of EMS has made promises, and actually I'll note that an email went around today from the Office of EMS this afternoon noting some of the requirements of this law and how the office is going to support the efforts of EMS agencies in the state. So the office is going to work as best they can to work with agencies and help you remain compliant and get up to speed with all the requirements here. It's also important to note that the goal here is to really be altruistic and what I call patient-centered. I've always said, and people who are on this call who know me well, I've said this many times over my career, it's not about me and it's not about you and it's not about your department. It's about that guy or gal that's laying on the ground looking up at you asking for help. And it's about what's best for them. And this law, I believe, is very focused on getting data to fill in the gaps in what we know and what we don't know about what we and EMS are doing. Believe it or not, EMS is very strongly part of the healthcare system and part of the healthcare continuum. We are a critical access point for patients. When you talk about healthcare access, we're a big piece of that, and we need to know what we're doing better than we do. The maxim, if you've never heard it, is if you're not measuring it, you're not doing it. So our goal here for this law overall is to measure what we do and what we don't do. And the quote that I had when I spoke to the folks in Trenton was that they don't want to be the police of this. It's not here to come out and to be punitive and to hammer people. It's really designed to be collaborative and to work with you to make the system overall better for the patients. And I will tell you at the end of the day, I believe that this law will go a long way towards that effort. So I'm flipping slides here. You should see the slide that says about the new law. This law actually passed pretty quickly, to be honest with you. It was dropped originally late May, early June, and it was signed in July, fairly fast-tracked here at the end of this legislative session. So it was signed on July 21st of this year. It goes into effect 180 days. So legally, this law takes effect January 17th of 2018. So the law is really pretty straightforward, and you can look for it on the legislative website, and we're happy to provide the copy of the law as it passed that we have. If anybody needs it, you can contact us offline. It has three main elements that it addresses. So what we're going to do here is kind of go in reverse order as the law is written and kind of get down to the meat of what the law covers third. So just for your own edification, I'm going to flip slides here now. And you should see a slide that says New Jersey EMS Task Force. The first thing that this law does is it writes into statute that the New Jersey EMS Task Force exists and exists formally under the Department of Health under the Commissioner's authority. That's a big deal. If those of you who have never heard of the task force or aren't that familiar with it, the task force is a collaborative group of people and agencies and resources, trucks, apparatus, trailers, communications stuff, staging materials, that was put together after September 11th, when we all identified collectively that we really had to beef up our collective ability to respond to big events. And these can be planned events. We do things that we know are coming in advance, like the New Jersey State Marathon every year. And there's sometimes unplanned events. For example, the task force deployed to the Hoboken train wreck a few months ago and helped out there. These agencies, if you're not a task force agency, you can certainly look at joining and sending people and resources. Basically, they have grant-funded apparatus and equipment that they give to various agencies around the state, and they maintain it and they use it as they need to. But when they're called to deploy to something like the Hoboken train crash, they will send their people and send their apparatus up to the event or down to the event, depending on which way we're driving that day. You may have noticed there were a lot of medical ambulance buses that deployed to the Hoboken train crash to be prepared for sheltering patients and moving patients and doing that in mass. A lot of those medical ambulance buses were purchased as part of the task force, and they exist under that auspice. The task force was formed very loosely originally, and it was a very collaborative group, but it didn't have a lot of formal structure. And this law will allow the Office of EMS and the Commissioner of Health to put some more formal structure into that and to support those operations more over time. Frankly, it is a wonderful thing for the state of New Jersey and for all of you. Someday, as we are EMS providers, you will have the opportunity to work with the men and women on the task force, some of the finest people I know. I worked with the task force for 2 years recently in an advisory capacity, had a wonderful time working with them, and I think that this is a great opportunity for the state of New Jersey and for the EMS system. The next thing is a really interesting change where instead of addressing the true EMS entities, we're going to have the Office of EMS have the ability to collect dispatch data from dispatch agencies. And as we all know, dispatch in New Jersey is very fragmented. It's really all over the place in police departments, hospitals, private companies provide EMS dispatch. The requirement now is that any agency, regardless of type, that provides EMS dispatch services will have to report the dispatch information to the state. And you can imagine at the next slide, we're going to talk about how the patient data is reported. A big piece of that is also going to be ensuring that we're capturing the dispatch data as well. So the dispatch data is going to be collected electronically. The office is going to work with the existing computer-aided dispatch systems, and I'm pretty sure that most of the systems, if not all of them in New Jersey, collect that data electronically to try to capture it electronically. So it won't be an over difficult process for anybody to push that data down to the state. Any data that comes out and the programs that they use to collect that and to review the data will be made publicly available. The response time data is going to be publicly available. It's not specified at this point whether the rest of that data will. But the goal here is going to be to look at performance metrics and protocols based on data. Which calls do we dispatch paramedics to? Should ambulances be responding lights and sirens? That type of material, as we collect data overall in large quantities, we can make much better decisions as to how we want the system across the state of New Jersey to run. If you look at the next slide on mandatory dispatch data, it's specified very clearly. They want the date, time, and location of calls. They want to know what the call for emergency response was. They want to know the identity of each EMS provider that was dispatched to the scene. And they want to know, and this is a nice open-ended slide, they want any other particulars as may be relevant or required by the commissioner. So there will be regulations that come out from this later on that will be in greater detail. And when the state sends those regulations out, it will show specifically how and who and when and what information needs to be collected. So this is the minimum data that's going to be collected. I would certainly expect that the state will require a great deal more information from the dispatch centers A lot of that's already captured in the dispatch systems already, so that shouldn't be difficult. But I would also expect that it wouldn't be any information that doesn't live in the dispatch centers. This is designed to close a loophole that would otherwise be unavailable. If a unit doesn't respond to a call, or they're canceled and don't write a report, or you have multiple units that respond and it's not captured anyplace else, this will allow you, or allow the state, to get a better picture, a more complete picture of what information what happened on each emergency call in the state. And that's the goal here, is to really capture a complete picture of every emergency call for ambulances across the state of New Jersey. So the third piece of this law, and really the meat of it for our purposes here, is the EMS data, the patient data that we're going to capture. And I'm going to pass the microphone to my partner, Margaret Keavney, to talk about the NEMSIS data.
Hi, good evening, everybody. So if you've heard NEMSIS but didn't know what the letter stood for, here you go. It's the National EMS Information System. And basically what it is it's a standardized data format. So NEMSIS data is just the information that we collect from the patient care encounter, but defined down at a very granular level so that we're all talking about the same thing when we use the same word. So if you look at something like response time, if we compare one crew to another, or how the agency did this year versus how they did last year, or how an agency in another part of the state compares to our own response time, we need to know that we're measuring response time the same way. Are we saying it's from the moment the wheels on the ambulance start to roll, or is it from the time that the crew gets into the cab and says we're en route? And that way we can compare things and find out if we're getting better, if we're getting worse, and where we are as compared and benchmarked to the aggregate data. And it's the same idea for an intubation attempt. When the blade crosses the teeth, is that when an intubation attempt starts, and are people using different definitions in order to get better numbers? Well, while using NEMSIS data, you're going to represent that you are using the same definitions as everybody else. So that's basically NEMSIS. It's a great big electronic database for the whole country, and it allows us, from a public health point of view, to get an idea what's going on, and it also allows us as individuals and individual agencies to compare ourselves with the average. So this law was passed by our legislature, and it is not a regulation like 840 and 841. And what this means is the legislature could decide who it applies to. And they decided not to make it apply just to licensed ambulance services under Section 26(2)K of the statute, or the regulations I just mentioned. They said it applies to anyone who provides pre-hospital emergency medical care, whether you're basic life, advanced life support, air, and whether you're paid, volunteer, you pay your employees, you charge for your services, it applies to everybody. So even though we're used to, under Title 27, the Highway Traffic Safety Act, there being an exception for the regulation of volunteer first aid squads, this statute does not make that distinction. This statute specifically says this data reporting requirement applies to those volunteer agencies. So that probably covers 99% of the people who are on the call right now. So what is it that we're going to have to report? What Matt went over was what the dispatch centers are going to be reporting, and this is what the providers have to report. And I'll just direct you down to the very last bullet point, and it's the same thing. The statute has said anything that the commissioner decides is relevant or required will be set forth in regulation that we have to report. But right now, the bare minimum would be the date, time, and location, nature of the emergency. This is going to be interesting because it's going to be different from the dispatch nature that the dispatch centers report because, as we know, often they are not the same thing. What treatments including if you give Narcan or EpiPen or aspirin or anything like that. The state wants to know the name and certification of every EMS provider on the unit and the identity of any other EMS provider agencies or individuals responding to the call. And that's going to help them determine if they're looking at the same patient numerous times, because they'll be able to cross-reference with those bits of information. The other thing that they want to know is, what's your patient outcome? Did you leave them where you found them? Did they refuse? Was it released to BLS or give to paramedics to transport? Did you hand them over to the flight team? And if they went to the hospital, which hospital did they go to? And, of course, death is also an outcome of the encounter.
And it's important to know that if you'll see a lot of overlap between this data and what the dispatch centers are going to report, as much as possible, a goal of this is going to be to mate up the dispatch data to the patient data proactively, because it won't always match up. There'll be times when you were canceled or times when you didn't respond to a call or there was another disposition. But as much as possible, mating these up, and there are electronic ways to do that. At the end, we'll talk a little bit about bridges to CAD programs and the billing software if you need them. But to mate up the dispatch data to the electronic patient record data early on will make this process easier for you, frankly, and just as important, easier for the Office of EMS.
So for those who are using electronic medical records, you probably already record all of this information into your own database. So the next question in our who, what, when, where, how, and why is, when do you record it? Well, statute doesn't specifically say that, but we do know what the Department of Health expects, and they expect that the hospital is going to be getting a copy of the patient care report within 24 hours after you deliver the patient to the hospital. So I think that it is reasonable to expect that when the regulations under this statute come out, that that's going to be about the amount of time that you're going to have to put all of that together. It is possible that they will say you have to report it weekly, monthly, quarterly, but since you're already going to have all of the information in a closed patient care report within 24 hours, the automation that the electronic patient care report vendors have got will make it so that that probably will be able to be reported right away. Now, if you are doing paper patient care reports, it might be different.
And it's, again, one of the conversations that I had with folks at the Office of EMS about this is it's really important for us in EMS to remember that this is a patient care record. And as healthcare providers, this is part of the continuum of care, making sure that the folks in the hospital know what we did and what we didn't do. And they make patient care decisions based on that. It is very, very important that they get that information. And I believe that this will be, or the final regulations on this will probably mirror 840 for a 24-hour turnaround to get those patients in or get that information in so that it gets to the hospital within that period of time, because they're the ones who need it as much as the state does.
So where does all of this reporting take place? Well, if you've got your tablet at the in the back of the ambulance, and that's when you fill out your information when you're transporting the patient to the destination, you can do it then, and then once it's in the database, it can be automatically slurped up. Maybe you wait until you drop off the patient, and that's when you complete your patient care report, and in that case, it will be a little bit later. And for those who choose to stay on paper patient care reports, it's going to be duplicate work, but at some point, somebody's going to have to take that paper report and take the NEMSIS data points and enter them into some sort of web portal or app in order to have that information reported to the state. So it will be quite easy and seamless to the clinical providers if you are already on electronic medical records. It will be a little tougher if you either have to move to electronic medical records because you're not using them now, or if you have to have somebody do all of that work after the fact. So it's always why. Why do we have to give this information? And For the state, of course, they want to be able to do key performance indicators. They want to improve the system. One of the impetus behind the bill was we've got an opioid epidemic, and we need a way to measure, to count. How many times do we give Narcan? How many times do we get dispatched to the kind of call where we might expect that? How much Narcan are we giving? And where within the state are we having the overdoses and the needs for Narcan? So that's kind of one of the things, because as you know, Governor Christie is also at the federal level in charge of fighting the opioid epidemic. So that's one of the reasons that he was happy to sign this bill. But just like any patient care reporting and any documentation, this data can be used to help the patient. It helps with continuity of care, the documentation from further down the line. Other care providers can look at what we did. It really helps the leadership of the organization do some quality assurance, quality improvement. For those who have research departments, it makes it so much easier to get so much research done once everything is digitized and standardized. And finally, for ourselves, to be able to know, I know how many tubes I did, I know how many patients I did CPR on, and I know how many motor vehicle accidents I went to, it's helpful, and it lets us know more realistically how much experience we have. So whether it's for you individually or for the department to determine what your competency may be, having all of that data on an individual basis is something that will definitely be helpful. And so as we've been sort of brushing against for the last few minutes, the NEMSIS compliant EPCR systems will automatically have this information. The department is going to have to come up with a way for providers to enter this information if they do decide to do it on paper. OEMS has decided to offer the software to any EMS provider in the state free of charge. And there are other EPCRs besides the image trend one that the state gives out for free, one of them being our sponsor, emsCharts. Another one is Zoll. There's Safety Pad. There's other providers that will do that. And while looking at those, you've got to make sure that you've got one that is NEMSIS compliant and that will have built into it moving this data from your records to the state's bridge to have the data go where it needs to go. So here is Matt to talk about a maybe intended, maybe unintended consequence of this law.
So if anybody did not get it, the email came out late this afternoon from the Office of EMS regarding this initiative. And they gave more information in that email about the offering of the image trend product from the state and other pieces of information about compliance with this law. Again, as we can offer the slides and the other materials to this to folks offline, if anybody didn't get that, you can always reach out to the state, or we'll happily forward that email along to anybody who needs it as part of the materials from this webinar today. So unfortunately, I have to go down a different road now, which is the HIPAA road. Because this is, I know, the bane of a lot of EMS providers' existence, and the bane, frankly, of a lot of healthcare providers, but we got to talk about it. So for those of you who are not intuitively familiar with this, because you haven't had it beat into your head for the last couple of decades, let me give you a quick primer on HIPAA. It's the Health Information Portability and Accountability Act. It is one P, two A's. The other HIPAA is the thing that you go to the zoo to find. So this one is from 1996. And the regulations from this came out in 01 or 02. So this has really been in force now for a very, very long time. And it sets minimum standards for health information privacy and information security. It's important to note this is a minimum, not a maximum. And your agency or your state may provide additional requirements above the minimum that HIPAA sets. HIPAA is still a pretty good place to start for things, even if they go above that. Another important note, and this is something that we as the lawyers see fairly frequently, is you can't sue somebody for a HIPAA violation. The law does not provide for a private ability to sue for a HIPAA breach. The Office of Civil Rights, OCR, which is an arm of the U.S. Department of Health and Human Services down in Washington, has exclusive enforcement authority for HIPAA claims, for HIPAA violations. That being said, you can have a state case where you're sued for a data breach if you can prove some kind of damages. So for a regular HIPAA data breach, if something happens, you don't need to prove that you had a bad thing happen to you. It can just trigger an OCR enforcement. We'll talk about those at the end of this. It's important that for someone to sustain a state right of action, they need to have some kind of actual damage, identity theft or some other negative outcome that came from that. It can still happen. So don't think that you can't be sued for a HIPAA violation, because you can. So in 2009, there was a thing called the HITECH Act, and that passed to fix some of the loopholes with the original HIPAA and tighten up a few things. One is it expanded coverage of HIPAA to what we're going to talk about business associates in a few minutes. Previously, HIPAA wasn't totally applicable to business associates, and this expanded that. And it expanded the breach requirements. Originally, when HIPAA came out, medical records were still mostly on paper, and the law started to anticipate them going electronic. Today, almost every medical record that we have, with some exceptions, is not paper anymore. They're electronic, which means it's really easy to lose a hard drive or a thumb drive or have somebody penetrate your computer and access your records and get a ton of records at the same time. So because of that, the HITECH Act in 2009 expanded those requirements and made them a lot more patient and consumer friendly. Unfortunately, that puts a lot of more responsibility on us as healthcare providers. So there's three really important terms you need to know in your life for HIPAA. The first one's called PHI, Protected Health Information. And this is basically any information about an individual's health condition that you can lock back to an individual person. That's very, very broad, okay? There have been a lot of HIPAA breaches that have taken place in the media, in social media, and in other venues where the information didn't have the person's name specifically on it. But there was enough other identifying information that came out around that allowed you to connect patient information to a specific person. That's all you need to qualify as PHI. It's very, very broad. So consider that term on the next slide when we get to that, when we talk about why the HIPAA will apply to everyone here, including you if you don't bill. The next thing is what's called a covered entity. A covered entity is any healthcare provider that transmits the PHI electronically for any HIPAA-covered transaction. Again, the next slide will talk about that in greater detail, but it doesn't require billing. It just requires a HIPAA-covered transaction. Finally, as we noted, there's a thing called a business associate, a BA. Our firms, XPAN Law Group and Keavney Streger, if we do work with any of you in the future, we would become your business associate. We execute a contract. It's a short piece of paper we have drawn up that says we're going to have your PHI and we're going to hold it just like we would hold your PHI if you were the agency. Basically, that's all it says is if something happens, we're going to use the same security standards and privacy standards that you as a covered entity have. Covered entities are really only three things. You have to be a healthcare provider, you have to be a clearinghouse of information, or you have to be an insurance company, a healthcare insurance company. That's why a lot of people will see, and it's a common question we get asked, is why can this agency or this person give this data out? They took pictures of something or they did some other thing. They may have done some wrong, but unless they're a healthcare provider, they don't become a HIPAA-covered entity. So that's why that subtle distinction there is very important. So to talk about whether you are or are not a covered entity under HIPAA, you have to look, and it says, and this is the law. If you can Google this, you can look it up, and we'll provide these slides to everyone and a recording of this offline for you later on. But the law says that if you transmit any health information electronically with a transaction, you become a covered entity. The transaction means sending it for financial or administrative activities related to healthcare. So that means you can bill for it. That automatically makes you a covered entity. But if you're sending it for administrative activities, that qualifies you as well to be a HIPAA-covered entity. And it goes further to define the healthcare claims or equivalent encounter information, which in this case, I think the information that this law requires very squarely fits into the administrative activities transmitting its encounter information. And for that reason, we believe very strongly that HIPAA squarely applies to all of the EMS agencies in the state of New Jersey under this law. My partner, Margaret, had contacted the Office of Civil Rights to speak to them about whether there were exceptions for volunteer agencies or small healthcare providers that don't have a lot of transactions, that don't have a lot of volume, or have other difficulties potentially in complying with HIPAA. And the short answer is no. There isn't any exception for being a volunteer. There isn't an exception for being a small provider. If you're a single physician's office and you use a small medical record system and send Medicare or other billing information or any other information electronically, even sending prescriptions to Walgreens qualifies. So those very, very small doctor's offices all have to be HIPAA-covered entities now also, and have for a long time, by virtue of this law applying and basically requiring, or essentially requiring, every EMS agency in the state to send medical records and patient information in some form to the state, even if you don't transmit the name of the patient. That will not obviate you or not prohibit you from having to still comply with all of the HIPAA regulations. So HIPAA's got a couple of things, and these are very, very detailed, very intricate responsibilities that we would take a great deal of time, frankly, to go into in detail. So we will talk about that at the end, how we can help you with that. Right now, you need to know that there's a couple of basic pieces that HIPAA needs to cover. The first is the security requirements, and this makes sure that the data, the PHI, doesn't get out into the real world. So you need to make sure that it is confidential. You need to make sure that the information can't be changed after the fact. Somebody can't go into the medical record and alter it in some way, and that it has integrity, and that it has availability to other healthcare providers, and importantly, to the individual. Because remember that the P in HIPAA is portability. That means that they should be able to take the patient's medical record and give it to other healthcare providers, take it and use it for whatever the patient really wants. At the end of the day, it's our record, but it's the patient's data because they have the right to it. It's very important under HIPAA, is that the information is the patient's. So there's three big areas where HIPAA security comes in. They're administrative, physical, and technical. Administrative safeguards are policies. They say who can get the data, what they can get the data for, who can't get the data, what limited uses you can do for it. And you'll note that in all of these requirements, there is a minimum access requirement. You can't access the full medical patient record if you're just doing billing. You don't have the right to do that. If you're doing quality improvement, you would probably have the ability to look at all the patient information, but maybe not billing information. We really want people only getting, the fewest number of people getting the minimum information necessary. So the policies will limit who, what, and how. Rebecca?
And it's really important that basic tenets of cybersecurity play into this, and that's what the HIPAA security regulation really say. They're talking about, building on these cybersecurity, and we all hear about it every day. But for example, Matt's talking about if you're billing, you only have access to the billing records. It's the principle called least privileges. And so everything starts to feed into itself, and you have to understand that with every security, with every system, you have these three pillars. And the HIPAA security guidelines and the procedures set forth by NIST really play into that and help to form this framework of how you're going to structure your systems, how people are going to access them, and how you're going to safeguard them, both from a technical, physical, and just security standpoint.
So the second requirement is physical. Physical is pretty much what you'd expect. If you've got something tangible, it's behind lock and key. You don't get the key to every person. It's in a place where the general public doesn't have it. It can be other physical requirements as well. For example, if anybody here knows me well, you'll note that I have a privacy screen protector on my phone because we get PHI as a healthcare firm. We get other, frankly, secure information that we don't want the world to be able to see. So I have, because I travel a lot and I use my phone extensively, I have a privacy screen protector on my phone. You'll see a lot of people with those on their laptops or other requirements that you can't sneak up behind somebody and take a picture of their screen. I've seen mirrors actually put on computer monitors to see if the person can see if somebody's sneaking up behind them. So those are physical safeguards. And technical safeguards I'm going to overwhelmingly leave to my colleagues from XPAN, as they're the experts in that area. But technical are the encryption standards, the password standards, The other and they are very difficult to learn and to comply with. I won't lie to everybody on this call right now. I've learned a great deal working with Rebecca and Jordan about the technical security requirements for computers, things that I'm pretty good at this, and I learned a great deal from them because they are the experts in this. And this is extremely challenging stuff to be compliant with. As you can imagine, it's constantly evolving, and it's fairly arcane computer requirements. So the HIPAA's privacy requirements talk about what you can do internally to use PHI and what you can do externally to disclose PHI. It's important to note that for any of these things, you need the consent of the patient to use it unless there's a reason in the law to use it. So if the patient says yes, you can do it for any reason. You can do whatever they let you use the information for. If they say no, you can't. However, there's a lot of exceptions in the HIPAA privacy rule that say when I can use HIPAA information without the patient's express written consent. The three big ones, and everybody needs to know these three, we will beat them into your head over time for HIPAA, are what we call TPO, treatment, payment, and operations. If I'm treating the patient, I need to be able to give information to anyone else who's treating the patient. Someone else doesn't come up at the scene of paramedics, or you don't drop the patient at a hospital and look at the hospital and say, well, I'd love to tell you about this patient, but I can't because HIPAA prohibits me from doing that. Absolutely not the way the law is written. I don't need consent. I don't need anything explicit. I don't need a business associate agreement in writing. There is an exception in the law that says for treatment, payment, and operations, I can use and disclose PHI. Again, the minimum necessary to do that, but I can use it. Payment, same way. If I want to get a face sheet from the hospital to get paid, and they have to give me basic billing information, I am entitled to that under HIPAA. It is not anything that requires a release from the patient or anything else. I very commonly hear people who walk into hospitals and they say, hey, we'd like to get billing information from this patient, and they say, we can't. It's a HIPAA requirement. It's not. Finally, operations, the ability to do quality improvement, to do other operational needs, to look at incidents that may have happened and disciplinary matters. There's a lot of things that fall under the umbrella of operations. That includes dispatching the ambulances and sending them to calls, why that qualifies overwhelmingly as operations. There's a lot of other HIPAA exceptions that exist. There's a judicial exception if the judge orders you to release information. There are death investigation exceptions. We will go into those in greater detail with people who need that offline, just so you know that they exist out there. It's important to know that this is the patient's information and they have the right to it. If the patient says, I want my records, you have to give them to them in a timely manner, in the manner which they want them, basically. So you can't say, we don't want to give this up or make them go to your web portal or do other things like that. Pretty much have to make the information available to the patient as they need it. Finally, I do want to note here, HIPAA is not a suicide pact. And that's my kind of quote on HIPAA, that this shouldn't handcuff people from doing their job. Remember that all of you were in an emergency room fairly recently, and what separated two of the beds in that emergency room was probably a curtain. It wasn't the magic curtain. It wasn't from Hogwarts. It doesn't deaden sound. It's just a regular curtain. Well, you want to prohibit that information from being audible to the next room if you can. HIPAA still contemplates that you need to be able to do your job. You need to be able to talk to people. And while you try to keep it from getting out, it's not crazy. The requirements of HIPAA should not prohibit you from doing your job. So you need a lot of stuff to be HIPAA compliant. You need a HIPAA privacy officer. So there's a single person who ultimately is responsible for making sure all of this stuff happens. You need policies on all of these things. You can imagine who gets what, under what circumstances, and how you do that, and making sure that people don't get what they're not entitled to. And having training at the staff level for all of the EMTs and paramedics in the department to know what they're allowed to do, and then your officers and executive people to know what they're entitled to do. Just because you're the chief of the department doesn't mean you may have the technical ability to get to every chart. That doesn't mean you have the legal ability to get to every chart under HIPAA. You have to have a reason to go in and do it. You should have a log or a system to access information, know who looked at the chart for any reason, and who you released information to. Most medical records electronic systems have an automated audit trail for accessing them, but not necessarily for who it went to outside the department. So you'll need a HIPAA log. If you print out a PDF and give it to the coroner's office, you need to log that as part of your HIPAA log. You need forms and processes to do all of that. You will need an audit at the end of this. to make sure that you're actually complying with what you think you're doing. And finally, you need training for all of the people involved in this. You need training for the staff, you need training for the HIPAA privacy officer, and for all the other people that have access to this to make sure that they're not doing anything that's going to get you in trouble. Because you can get in a lot of trouble for screwing up HIPAA stuff. The Office of Civil Rights investigates every single HIPAA complaint they get. If you have a very minimum HIPAA violation, and they're rare, but if you don't know and don't have any way of stopping the HIPAA violation from occurring, the minimum fine is $100. The maximum is $50,000. If you look at this and go up, willful neglect of your department, your policies, your processes, that intentional neglect, knowing neglect of the HIPAA rules that results in a HIPAA data breach is a $10,000 minimum if you correct it in 30 days. On day 31, you automatically hit the maximum fine of $50,000, and that's per record. That's per claim, okay? That's per incident, per thing. So if you have 100 medical records and they're all breached on a thumb drive, that's 100 $50,000 breaches.
And I was just going to add, you really can't highlight enough how important it is from a cybersecurity perspective, because you can have a very small breach. We have experience where the only limited amount of an email exchange was breached, but there was PII in there, and you had almost 1,000 separate incidences of somebody's personal information getting out. So again, you're multiplying that by 10,000. 1,000 times 10,000. That's just a very, very small breach. So it can't be stressed enough how really important it is to pay attention to all of these moving parts.
There are a lot more requirements under HIPAA that we won't go into now. There are requirements, for example, to not send electronic medical records that are unencrypted via email. It's one of those things we see fairly regularly is somebody PDFs a patient record and they email it without it being encrypted and password protected. That's an automatic data breach. Another thing that's considered an automatic data breach under HIPAA is ransomware. If your computer is infected with ransomware, the Office of Civil Rights considers that a presumptive data breach. So because your computer was compromised and people can get to what's in it, even if it's not stored locally, they can see what came across the computer. So let me now pass the microphone to Rebecca to talk in greater detail about ransomware and other cybersecurity issues.
So building off of what Matt just said, even if somebody sends you something that is unencrypted and you have it in your email exchange, because it's in your email exchange, if somebody gains access to that exchange and that unencrypted data is in there, you now have a HIPAA violation. The encryption is what protects it, and the statutes governing cybersecurity from the state, not even dealing with HIPAA. If you're just talking about straight cybersecurity statutes in the state of New Jersey, if you have encryption, you're okay. The problem is when you send or receive documents that are not encrypted. So basic tenets of cybersecurity, I always say to my clients, where is your data and what is it doing? You have to understand what you have and how it's speaking across the network, right? How it's speaking to your various platforms, how it's speaking to other platforms you're interfacing with. Every single time you interface with another platform, with another provider, with a BA, with another covered entity, you are coming up with a point of entry, a vulnerability point for a cyber attack. And it's really important to note that HIPAA requires it, and basic cybersecurity best practices state that you should have policies and procedures in place to address these issues. We're talking from a technical perspective. There are very, very easy things you can do on your back end to make sure that you have audit logs, that you have security logs, you have login functions, so you know who's logging into your system, how many times they attempted to log in, whether those attempts were successful, where they're logging in from. Are they logging in from a home computer, or are they logging in, in the station house? Where is it coming from? All of these things can help you from a cybersecurity perspective. One, cut off an attack. But two, if something happens and your systems are breached, they can help you to shore them up and to have a plan in place so that you don't have exposure of hundreds of thousands of medical records, that you can limit your exposure. So it's really important that there's someone at your organization that's responsible, who's in charge for all this, right? Because Joe does this and Mary does that, but one person really needs to be responsible for all of this. And HIPAA, again, requires it, and it's a cybersecurity best practice to have someone who is, in fact, in charge to make sure that these logs are being reviewed, that you're auditing, that if there is training in place. So I guess from a cybersecurity perspective, the most important thing that you can do is to make sure you understand your systems and how they're operating, and that you take these basic steps to ensure that you're not leaving the barn door open. It's a problem enough when the horse gets out, but if you left the barn door open, whose fault is it? So you want to make sure that you're shutting every door that you can, because cyber criminals are out there. They sit in their basement with their hoodies on, pecking away at their laptops trying to get into your system. So the important thing is that security is, I say it all the time to all my clients, security is a misnomer. Nobody is secure, right? Because you're out there, your data is out there, things are on the web, you're sending emails are not 100% secure, you're logging into public Wi-Fi, things of that nature. So you have to really make sure that you can take every precaution you can, because if a hacker wants in, they're coming in. But you don't have to leave the door open and with a nice welcome mat and inviting them into the front door of your home. So with that said,
Rebecca and I have talked extensively about this, and I just want to put a couple of final caveats on the discussion of security. Is number one, you need to understand it can happen to you. You don't have to be John Podesta at the DNC in the middle of a presidential election to have your email hacked.
In fact, most hacks happen to small businesses, and I would suggest that everyone on this call is what I would consider a small business. You're not the DNC. You're not Hillary Clinton that people are trying to get in. But the interesting thing is, even if you're not Target, the little hacker, he'll hit you on the way to get Target. He or she has no problem doing that. And they consider you to be the low-hanging fruit because you have invested the least amount in your cybersecurity. Most small businesses attribute less than 10% of their yearly budget to cybersecurity. That's a problem because the criminals know this, and they're trying to get in.
This happened to a small police department up in Maine last year where their CAD system, their dispatch system was hacked, and they had to pay Bitcoin to have their CAD system released because it was encrypted. They couldn't dispatch the police cars and get any of the records on the law enforcement side. That being said, this also happened last year, right around this time, May, June last year, at the MedStar Hospital down in Washington, D.C., and it shut their information systems down for 8 days. That's 8 days of a major teaching hospital in our nation's capital shut down. I will tell a brief story that when I was at Robert Wood Johnson several years ago, I had somebody send me a spear phishing attack, and they sent me an email asking for my password credentials to ostensibly to change the credentials. But obviously, when I looked a little closer, it was designed to have me give up my email and login, so my name and password, so that they could get my information and get into the system. And if I had gone in and typed that in, it would have been over. And if that happened to me, I'm sure it happened to many, many other people at the hospital back then. And that's how people jump into the system and they get you. This really can happen to you.
And what's really scary is even when you're the victim of a ransomware attack and you pay the Bitcoin ransom, which we very rarely recommend you do, you don't necessarily get the data back that you thought it's not in the format you thought it was in. It's changed. Plus, the jig is up at that point. That data has been exposed. It's been out there. You have a breach. There's no question about that. So you really have to, you have to understand that when you click on that link, because a lot of people click on a link just because they're curious to see what it will do. When you're seeing what it will do, it exposes your entire company, your EMS, brethren to a HIPAA violation now, because what it's going to do is it's going to let a hacker into your system.
Finally, I would note that it's very important that you have the policies and procedures. There's really two pieces of this. One is that you have policies and procedures and you follow all of these things. And the other is that you have HIPAA-compliant programs and systems. So I'm going to pass the baton here to Tara Savon, who is from Penn Care. Penn Care is a local vendor for emsCharts here in New Jersey, and she's going to talk about some of the benefits of emsCharts for you, especially as a HIPAA-compliant program and platform.
Good evening, everyone. Thanks, Matt. Now, I know that some of you folks are familiar with or currently using emsCharts. But for those of you who aren't, I want to point out just a few things about our charting system that specifically apply to what we've covered today. First, as Matt mentioned in some of the previous slides, this new law is requiring services to submit NEMSIS 3 data to the state. emsCharts is currently submitting that data automatically to the state of New Jersey every 10 minutes. We've also talked a lot about HIPAA. To keep that very short, emsCharts is a HIPAA-compliant solution for you. We've also learned that this law applies to all services, regardless of call volume or your billing status. emsCharts does allow you to tailor your account to fit the needs of your service while remaining compliant with the state. In addition to that, we do offer continuous customer service through Penn Care as well as through emsCharts. We're here to help you along the way through training and implementation, tech support, and any other questions or concerns that you may have throughout the entire process. And lastly, regarding the dispatch data portion, emsCharts has integrations built with numerous CAD vendors to help you with a seamless import of that dispatch data that they are requiring. We also integrate with numerous billing companies and softwares to help automate that process as well.
Thanks, Tara. I think it's really important for everybody to note that the automated processes for data sharing are a really, really big deal. The ability to share information between different EMS agencies, between your BLS and your ALS, between the EMS providers and the hospital. You may hear a term in the future called an HL7 interface, which is the system that allows your EMS chart or whatever PCR program you're using to push the data directly into the hospital's electronic medical record system, so it automatically gets appended and becomes part of attached to it to become part of a medical record. That's a really, really big deal for continuity of care, for patient care at the end of the day. I cannot overstate the importance of the data sharing and the automated data sharing process. So obviously there's a lot more to this law. There's a lot more to HIPAA. There will be more to come to help the EMS community. Margaret and I and Rebecca and Jordan have partnered up here, the foursome, the four musketeers, if you will, to work for the local agencies to create a program that will help them meet the requirements of these laws and to do it in a way that keeps you secure and safe. One single bad event from this, a single HIPAA data breach that you have to report to OCR, can destroy your agency. It can destroy the community's trust in your agency if you have to publicly report the data breach. Or it can shut you down completely, like happened to MedStar. And we really want to make sure that our brothers and sisters in EMS across the state don't have this happen to them. So to help with that, we created a program that will allow EMS agencies to use our services. We're offering this as a flat fee for $2,000 per agency. I do note that is for smaller agencies, and if it's a larger department, that might increase. But what we're going to offer is in-person training. We're going to come to your department. We're going to look at your best practices, look at your existing practices. We're going to train your people in good cybersecurity practices, passwords and information security and the HIPAA privacy officer requirements and the HIPAA training for everybody else, and then offer you policies and procedures and audit logs and all of the written requirements you need so that your agency is, number one, HIPAA compliant, and number two, information security compliant with industry best practices for people who live and die on information security in the industry. We're very happy to offer that, and our contact information is going to be on the next slide. I'm going to flip the slide now and leave it up. For anybody who needs it, these are our websites and these are our email addresses. You can contact any of us offline for support in any part of this. I will note that the slides, the law, the email that came out from OEMS today, and a recording of this webinar is going to be made available to all of the participants in here. And this is not proprietary. We're offering this information to anybody across the state. So if you have friends or colleagues who need this information and they could not be on the webinar today, please feel free to circulate this to all of them. This is really important stuff. It's going to really change the way EMS is done in New Jersey for the better. That being said, it is not going to be an easy process to get everybody where they need to be. And we are here to help you with that as much as possible. Rebecca and Jordan from XPAN Law Group are here to help you with that as much as possible. And our partners and our friends at emsCharts and Penn Care are here to do that as much as possible. So that being said, I'm going to pass the microphone back to Rick, euphemistically, because Rick is on the West Coast, and he's going to take questions.
Matt, we actually had a question typed in a minute ago. I'll read it. For officers collecting information to do their own QA and QC, are those officers allowed to have unlimited access to review the material, including treatment? And that came from Robert Z.
Yes. That's a very common question. You are entitled to have access to all of the information, except we expect that people will not use that access except the minimum requirement necessary to review what aspect of the chart they're looking at. That might be the full medical record. If you're looking at a full patient encounter and we're quality improvement efforts for that, it might be the whole thing, but it might not be billing information. But we would expect that you might be doing quality improvement for billing information as well for completeness. That's still an element of completeness of the chart. Rebecca?
And the other thing I would note is, while you're absolutely entitled to look at the entire record, you also need to be, when you're looking at it, you need to make sure that the system that you're using, however you're accessing that record, is secure. So, you're not using public Wi-Fi without, certain precautions in place. You're not on a home computer where there's, potentially viruses that can infect the system. There are security things in place that you need to be aware of when you're doing that. So it's not just that you can look at it, but you're doing it in a secure manner.
Yeah, and I will note here that I'm most familiar with emsCharts from my career, frankly, because most of the places I've worked have been emsCharts departments. All electronic PCR systems, regardless, have an audit trail. Every keystroke, every IP address, every page you view is logged. Who did it, the time, the date, where they were, what IP address they were at when they looked at it. So there's a check later on as to every last little thing we did on these records to make sure that the information is secure and that it wasn't breached and that we have that log of who was accessing it at every time. So there are systems in place on all of these to help you with making sure you're compliant with all these responsibilities. Rick?
Are there any other questions? If you do have a question, please push *6. That will take you off mute, and you'll be able to ask Matt and the team a question.
Bueller?
I don't see anybody coming off mute, Matt. You must have answered all their questions.
Good evening. Sorry, it took a minute to get to the phone here.
Not at all.
My name is Apu from Springfield. Thank you very much for your presentation tonight. One question based on the email that OEMS sent out earlier today. Is it safe to say that their regulations are going to require the dispatch info to get to the state via our ePCR instead of two separate data feeds?
I don't know that I can answer that question. I think it's the goal of the state to have that. I don't know if it will be fully implemented that way. I can certainly envision some places where there will be dispatch data that's not always in the PCR record. For example, and I'm just knowing the EMS system in New Jersey and not speaking critically, there are times and places where volunteer squads miss calls. They're dispatched for calls, they don't get out for a call, they were sent and ultimately did not respond. That would not be captured in an ePCR record. Most places, I doubt very much that that's captured. Under those circumstances, I would think that the dispatch center would still have a responsibility to capture that data and push it down to the state in some format, but I don't know how that's going to work.
Okay, thank you. We've been trying to get our dispatch info into emsCharts for a while, and this could be an impetus to make that happen.
I think this is an enormous impetus to do that. It'll save your people. It's called a bridge, a CAD bridge, a CAD, the computer-aided dispatch. And the bridge is simply a conduit or a connector between databases. So the CAD system has a database. The ePCR system, the emsCharts or whatever else you're using has a database. The hospital has a database. The billing company has a database. And the bridges are just a connector that lets the information go from one place to another in a format that they can speak to each other. I do know from having worked with them that emsCharts has bridges to many common dispatch programs already built. I don't know what you're using, Apu, where you are, but I think you could probably talk offline to some people here from emsCharts and Penn Care to see if there's a connector already built between them. But it saves a lot of trouble for your staff to get that information pushed from dispatch to the PCR system. It also helps with data validity. There's no questions of somebody changing either accidentally or intentionally, for example, your dispatch times, because it's getting automatically imported, and you have to go in and override that. And that helps the process for accurate data as well.
No, I know the tech definitely exists. It's personnel/politics.
Yes, this is, it's a great point, Apu, and I do want to mention it to everybody here. This is a double-edged sword. I recognize that for a lot of agencies, especially small volunteer agencies, there is an administrative burden here. There's a big list for people to get spun up on a lot of these requirements fairly quickly, and that's tough. By the same token, as you really note, one of the biggest ways you can go to your town or your governing body or whoever else is in charge of you, basically who holds your budget strings, and you can say, hey, I need more money, and stuff that you may have been asking for a really long time, and they said, hey, we don't have the money to do that. Now they got to find the money. So there are benefits for EMS agencies when new regulations come out and they want to make system improvements that are now required by law. So look at your system, look at where you have opportunities like Apu does to grow your system and to use this to help you.
Thank you again.
No, thank you. It's a great question.
And Matt, there was one other question entered. It was from Jay Kelsey. It is, what is the frequency, in your experience, of random HIPAA audits in the absence of a report of a breach in an EMS agency?
I'm going to pass the microphone to Margaret, who is sitting right next to me. Hang on one second.
The majority of HIPAA violations come to the attention of the OCR through either a complaint filed directly with the OCR, with a news story about a breach, and if the if the party that has been breached is a healthcare entity or another covered entity, they're going to look into that, and of course self-reporting. So it is not their main area of enforcement to go out and do audits, but the two things that are risky is if you are being audited for something else, that could come up. And if you've ever had a volunteer or an employee who is disgruntled or who is asked to leave the organization against their will, that often gives rise to a complaint directly to OCR, and all complaints must be investigated, even if they're ridiculous. So, the random auditing, not at the top of our list of things we're worried about.
Yeah, I agree completely with Margaret. I don't think that there's a lot of random enforcement activity. I think they have plenty on their plate right now. I have not heard of a lot of random enforcement activity. Frankly, I think there's plenty of complaints out there. People know what their rights are under HIPAA. It's been around for almost 20 years now in active application, and people fairly regularly know. They call lawyers. Like I said, I get calls on a regular basis for people who say, this hospital, this whatever it happens to be, usually it's a hospital or doctor's office, didn't hold my data to the level of confidentiality of HIPAA. I want to sue them. And those are always directed by me to the OCR because they don't have damages. But there's a lot of those. So I think, Rick, that's the answer to my question for that one. I think I saw something pop on the screen here, but I didn't have a chance to capture it. Was there another question?
There is. It's from Paula W., and it is, what I've read on the new legislation indicates that patient outcomes need to be reported. That's not an easy piece of information to obtain from hospitals after we turn our patients over to the ER, especially with a cause of death if the patient does not survive.
I agree completely with what Paula said. I think the patient outcome data, the way the statute reads right now, is disposition data, which is to say, were they treated, did they refuse transport, or did they die at the scene, were they treated and pronounced at the scene, were they transferred to a flight crew or another agency, was there some other disposition that might have happened? I don't know whether the state, frankly, is going to require clinical outcome data from the hospitals. If that's the case, then yes, it's difficult to get them to do this But yes, this law will help you enormously when you can go to the hospital wherever you are and say, hey, I know you don't want to give it a statute that says we're entitled to this and must report it to the state.
And for those of you on the line who are with MICU providers, yeah, that's something that we deal with every single day, that the hospitals just don't care that we're required by regulation to report this. Fortunately, OEMS knows this, and so if OEMS decides to change a regulation to require us to have hospital dispositions, as in admitted to ICU, discharged, died in the hospital, hopefully we will be able to deal with that at the time. But right now in the statute, although the commissioner can choose to change this, right now in the statute, transported to ER at hospital X is as far as we have to go. That's a great question.
Thanks, Rick. I was able to access the chat log here, and I see a few of them popping up, but I'm going to let you run that.
You bet. The next one's from Tony from Ridgewood, and he asked, he uses emsCharts, and is it safe to use emsCharts, and is it ready to go to send this information to the state, or do they need to complete other forms? And I'll tackle that one. Yes, emsCharts is compatible in the state of New Jersey. We do report on behalf of our customers right to the state via NEMSIS reporting, and we're, of course, also completely HIPAA compliant. So all the things that Matt and Margaret and the team talked about today are supported in the emsCharts system. So if you are using emsCharts, that's obviously a great solution, in our opinion, to report right into the state. If you have any questions on that, please contact either Tara at Penn Care or sales at emsCharts.com. And Matt, there's one more from Don V., and it is, I work for a career fire department using Alpine Red Alert software for RMS, NFIRS, and EMS charting. And I don't plan on using emsCharts for EMS. Instead, we plan on using this closed system. Do I need to build a bridge for reporting to the state through emsCharts?
So, Don, that's a great question, too, and I'm going to be totally upfront to tell you I don't know Alpine Red Alert well. I've never encountered that software before. I know that there were a lot of integrated programs, especially for cross-trained fire department EMSs that do NFIRS reporting and EMS reporting at the same time, and I'm guessing this is one of them. The answer is twofold. Number one, you need to make sure, and I don't know it, that Alpine Red Alert is going to be NEMSIS 3 compliant. So the first step in there is making sure that the data that is going in is going to meet what the state wants to pull out of that. Once you answer that question to the yes, you're going to have to find some way of getting that into the state's data bank and the state's data repository. So the answer is yes to that as well, or you would need some other way of doing it. I'm sure that if you're already using that software, if the bridge doesn't exist, you'll have to figure out a way to get a bridge, or you have to use a different system to get it into the state. But yes, one way or another, what's in Alpine Red Alert will have to get into the state data bank.
Great. Thank you, Matt. And, Matt, that's the end of the typed questions. If anyone else has another verbal question, if you push *6, you'll be able to speak. Well, Matt, I think that, and Margaret, I think that's the end of the questions.
Well, let me thank everybody. First, I want to thank emsCharts and Penn Care for their incredible support on this. While everyone recognizes that there is a commercial and a purpose in all of the things that we do, because we're business people, the goal of all of this was to get this information out to everybody in the state, regardless of what everybody does with it. We're thrilled with the support that we've gotten from emsCharts and Penn Care to help that happen, to help the EMS system grow and improve. And I want to personally thank Rick and his team and Tara and her team for their support in pulling this together for us. Of course, I want to thank Rebecca and Jordan for their support with this as well. They're great members of our team. They're great to work with, and I hope that some of you get the opportunity to work with them as well. I think you'll really enjoy the process. For stuff that's really arcane and difficult, they make it very approachable and very down to earth. As I said, I'm pretty dialed in on this stuff, and I've learned a lot working with them. And finally, I want to thank everybody, thank my partner, but finally, I want to thank everybody here for taking the time out today and taking the time out earlier today to be on this call and to be on this webinar and to participate in this to make the system better. You're all dedicated people. You're all hardworking. Many of you are volunteers who volunteer your time to make this happen. I respect that. We respect that collectively, and we want to work with you to make the system better. Again, at the end of the day, the person who matters the most in all of this isn't any of us. It's the man, woman, or child that's on the ground next time looking up at us, asking us for help, and this helps us do our job better for that person. So let me thank you all one last time, and Rick, we're back to you.
Well, again, thank you. It's a pleasure to support you, Matt, and Margaret, and Jordan, and the team. And if anyone has any questions, feel free to contact any of us through this contact information that's up on the screen right now. As well as Matt and Tara mentioned, we have recorded this, and we will be making that available. And again, you can contact any of us, and we'll make sure that we get you a link so that you can download and watch and share this presentation and any of the audio that you heard as well. So again, thank you all, and have a great evening, and we'll send that out this evening. Thanks.
Thanks, guys. Take care.